All right, let's see. I am not a fan of the mic, so. All right, good afternoon. Again, my name is Melissa, and this is Anastasia, and we are with Tennessee Department of Health. Let's see, got the clicker? Yeah. Okay. So today we're going to talk about hepatitis C, what it is, how it's transmitted, how we treat it, how it fits into the opioid crisis, and we'll discuss some common barriers to accessing care and some resources throughout Tennessee to prevent transmission, including harm reduction. All right, so before we start teaching and talking, we're going to play a little game with you all. So if you don't care to participate, it's a true or false game. So true or false, hepatitis C is the most common bloodborne pathogen in the United States. True. Yes, great job. All right, true or false, persons who share needles, syringes, or other equipment used to prepare or inject drugs are vulnerable to acquiring HIV and hepatitis C. True, yes. True or false, there's a vaccine for hepatitis C. False. Do you know which hepatitises have a vaccine? B and A, yes. True or false, hepatitis C can live on environmental surfaces or outside of the body for up to 6 weeks. It's true. This is a very hardy, thriving virus. All right, true or false, most people with hepatitis C do not experience symptoms. True. Around 80% have no symptoms. All right, I think you all know a lot about Hep C already, so.
Cool. Well, thank you for participating in our pop quiz. On the slide is a graph that you're probably very familiar with. It shows the timeline of the opioid crisis and the 3 major waves that coincides with shifts in drug use and the supply, as well as the policy landscape in the United States. We first see that surge in the late 90s, and that coincides with the rise of opioid prescriptions. The second rise starts in 2010 due to extreme policy responses to prescription opioids, and there's little or no support or alternatives to those prescribed opioids. And that's when we see people start to use heroin for pain medication. And then the third wave begins in 2014 when overdose deaths take an even more concerning jump due to the introduction of synthetic opioids like fentanyl, and that is just introduced into the drug supply market. In 2015, we also see a lot of stimulant use start to rise. So fatal and non-fatal overdoses, as we talked about earlier today, are especially a major concern in Tennessee. And according to the latest annual overdose report from the CDC, Tennessee has the second highest overdose rate in the country. And we have more than 3,800 deaths due to opioid use in Tennessee. And you can also see on this slide, the darker blue on this map means that they have higher rates of overdose deaths, especially in our eastern region. We also see that in Shelby County. So, backing up a little bit in our timeline, although we're seeing devastating increases in overdose deaths, it wasn't until 2015 when we really started to see SSPs become more widely, Certain Services Programs, also known as SSPs, they began to be more widely accepted at the governmental level and at the public health sector level. And this change was in response to a concerning HIV and hepatitis C outbreak in a small rural town in Scott County, Indiana. And you're probably thinking, why is this relevant to us in Tennessee? Because it's Indiana. Well, this county is not very different from a lot of our counties. It's very small, rural America with a population of about 24,000 people. And it has been notably impacted by the opioid epidemic, poverty, and unemployment, like many of our counties in Tennessee. Previously, Scott County saw 1 to 2 new people a year with HIV, but between November 2014 and October 2015, they saw 181 people in Scott County newly diagnosed with HIV, and 92% of these people were also diagnosed with hepatitis C. This is obviously a huge alarm bell for public health officials. They began to question if other places in the US that also, again, were that rural, small town America, could they also be the next Scott County? So the CDC conducted a study to determine if there were other counties with similar statistics that could eventually lead to the next HIV hepatitis C outbreak. So in Tennessee, all counties are vulnerable to an HIV hepatitis C outbreak due to injection drug use. You can see on this map, the darker the blue, the more vulnerable a county is, but again, all counties are vulnerable. So with that in mind, today we're going to talk about hepatitis, which is an often overlooked disease that can lead to severe consequences if not treated, especially for people who use drugs.
All right, so on this slide here, you can see the liver. I think everybody knows what the liver looks like, but here we go. This is the largest vital organ in our body. It's around 3 to 4 pounds. This organ can regenerate itself even if up to 90% of it had been removed. So it's the only organ in our body that can regenerate. As you can see though, the liver has many functions. It is our sponge, our filter, so it's a very vital, important organ for us to keep in good shape. With hepatitis comes cirrhosis or decompensation. So compensated liver cirrhosis, the liver is still able to function, but once we hit the decompensation stage, which is like failure, the liver is no longer able to function and has serious complications, and you'll see someone with jaundice and ascites. To assess liver damage, they can do a biopsy, which is with a needle. It's invasive, but it's the gold standard. Then we also have laboratory tests where they'll check like the liver enzymes, the ALT, the AST, and then of course we have imaging such as the FibroScan and ultrasound. Now we're going to go over some basic information about viral hepatitis and focus on hepatitis C. All right. Sorry, I train a lot, but I never speak. So this is, whew.
You got it, girl. You got it.
All right. So what hepatitis means is inflammation of the liver. So hepa is the Latin term for liver, and then itis, of course, is inflammation. So things that can cause hepatitis is such as excessive alcohol use, drugs, toxins, chemicals, and exposure to a virus. And of course, today we're talking about viral hepatitis, specifically hepatitis C, and that is inflammation of the liver due to a virus. Hepatitis A, B, C, and D, which we do see here in Tennessee, all 4 of those. They vary in the way they're transmitted and the treatment for them and the recovery. The symptoms for hepatitis are all the same, such as the nausea, the vomiting, the fever, the fatigue, loss of appetite. However, majority of the time symptoms are not present for like hepatitis C and B. A, if somebody has hepatitis A, they'll have symptoms pretty much right away. So acute versus chronic. So acute is the initial stage of hepatitis, which is that first 6 months. If an individual does not get treatment to cure like hepatitis C, or their body doesn't clear itself, it'll move to the chronic stage after 6 months, and they will need treatment for sure after that. Typically, if there are symptoms, they're most visible during that acute stage. The chronic hepatitis B, C, and D can all go to a chronic. Hepatitis A does not go to chronic, as when someone contracts it, they're sick for a few weeks, a few months, and then they're done with it. Chronic Hep B, C, and D can lead to serious liver problems. Okay. So hepatitis C is known as the silent killer. It is the most common cause of hepatitis C, or excuse me, of hepatitis. It can become chronic if it doesn't resolve itself on its own, like I said earlier. And there is a cure for hepatitis C, and it is the only known virus with a cure at this time. Without the cure or it clearing itself on its own, it can lead to serious liver damage where they would need a liver transplant or would lead to death. But again, this virus does have a cure. The way hepatitis C is transmitted is like sharing injection drug equipment, your syringes, the needles, the water, the cookers, anything that could have that blood-to-blood exchange. It can also be spread through the sharing of personal grooming items, fingernail clippers, razors, toothbrushes, glucometers, like things to check someone's blood sugar. It can also be shared through tattoo needles, tattoo ink, piercing needles. So anything that could cause that blood-to-blood exchange, the hepatitis C can be transmitted. It's typically not listed as sexually transmitted unless there's a blood-to-blood exchange. All right. So sorry. All right, so before someone has hepatitis, of course, their liver's in normal shape, of course. So once they've contracted like hepatitis C, as you can see here on the slide, sorry, I'm having to look over here, 55 to 85 progress to chronic hepatitis. And then after that, about 20 to 25 years later, we'll go into cirrhosis. And then you'll see the liver cancer and end-stage liver disease. Now, if someone has HIV and hepatitis C, these statistics do not apply as it will progress more rapidly and quickly with someone with HIV. And this slide actually demonstrates the timeline where someone can have it, and then 20 to 25 years later, then we have cirrhosis, and then 25 to 30 years, that's when we're looking at liver cancer, liver failure, and death. So hepatitis C was not discovered until 1989. Prior to 1989, it was named non-A, non-B hepatitis because they just did not know what it was exactly. They knew it was hepatitis, but didn't know what. In 1991 is when we saw the first treatment for hepatitis C, known as interferon. How many of you have heard of interferon? It was pretty rough stuff, right? It put people in the bed, made them really sick. The treatment lasted 6 months to a year, and it was only a 50% cure rate. We did not have an oral medication until 2014, 23 years later. Now, you'll see on this timeline in 96, hepatitis C infections declined, but however, in 2007, deaths from hepatitis C surpassed HIV in the US. So that we really were starting to notice we've got an issue. So we're going to take a sideways step here for a moment and talk about hepatitis A and B. So hepatitis B is spread through blood, but it's also spread through other bodily fluids and through sexual contact. It can be an acute case or a long-term or a chronic case. It's spread through like sharing of injection drug equipment, sexual contact. So, sorry. Hepatitis A is different. It is spread through the fecal-oral route. So if someone has hepatitis A and say they go to the restroom and they don't wash their hands and then they prepare you something to eat and they have it, they could potentially expose you to hepatitis A. So we do see hepatitis A more commonly in like our homeless camps because they don't have ways to wash their hands. Now, the good news about hepatitis A and B is it is vaccine preventable. So in 2020, CDC updated their recommendations that everyone over the age of 18 should be screened at least once in their lifetime for hepatitis C, and all pregnant persons during each pregnancy. And then You also see here, they say get testing for anybody with HIV, if they're receiving hemodialysis, prior recipients of transfusions or organ transplants. And something I failed to mention earlier, prior to 92, blood products were not screened for hepatitis C. So it was spread through organ transplants or blood transfusions prior to 92. They also encourage healthcare, emergency medical, and public safety personnel to get checked after needle sticks, sharps, or mucosal exposures. And then we also say children born to a birthing parent living with hepatitis C also to be screened. Now we do encourage routine periodic testing for those with ongoing exposure, such as injection drug use. If they're in active use, we'd say get tested every 3 to 6 months. And then if they're receiving hemodialysis, to be screened on a routine period. And then of course we say test anyone who wants to be tested. So hepatitis C, it's a 2-part series test. We've got the antibody test. If that is a negative result, that tells us that you've not been exposed or you're in that window period, if it's that first 6 months. Because it can take up to 6 months for hepatitis C to show. We would provide that individual with education, how it is spread, and how to protect themselves. And then if a person gets a positive hepatitis C antibody result, we would refer them to get the confirmatory, which is a blood draw, to test for that RNA. Oh, there we go. So the RNA test tells us if someone is living with hepatitis C today. And if they are, then we're going to guide them to treatment. But if that's a negative result, we're going to let them know your RNA is negative, how it is spread, how to protect themselves from acquiring hepatitis C. And then if they have that positive result, we're going to guide them to where they can go to get treated. Because again, this virus is curable. And something I failed to mention, once somebody is positive for the antibody, they are positive for the rest of their life. Their body has seen it, they cannot unsee it. So with hepatitis C and HIV, 21% of individuals with HIV also have hepatitis C. And then, as you can see on the slide here, hepatitis C is 10 times more concentrated in the blood than HIV, and it spreads more easily. And then it progresses again more rapidly with individuals living with HIV as well. So this slide shows the connection between HIV, hepatitis C, and the opioid epidemic. So 8 in 10 new hepatitis C infections in the US are transmitted through injection drug use. And then 1 in 10 new HIV infections in 2015 were due to injection drug use. And then this slide, this does not make us proud for Tennessee. There's a lot of things Tennessee could be #1 in, like our sports or things like that, but not this. But unfortunately, we're in the top 3 of the top 10 states for hepatitis C. So we're part of that Appalachian corridor. So where the opioid epidemic has hit us hard, and then of course we have high rates of hepatitis B and C from that. All right, so the good news for hepatitis C, even though we don't have a vaccine, we have a cure. And the cure is very accessible now. So the treatment for hepatitis C is an oral medication. It's 8 to 12 weeks. That will be dependent on what the provider states that you need to take it for and what medication they put you on. There are several medications now for hepatitis C. They are pills. Some of them can also come in like granules where they can mix it in like yogurt, ice cream, applesauce, because children as young as 3 years old can be treated for hepatitis C. And as we know, they're not going to swallow pills, so it's great we have those granules where they can help take it. Typically, side effects for hepatitis C treatment now is minimal. Headache, fatigue, nausea, dizziness. Some people have more symptoms, some have no symptoms. It just varies on the person. And then it is highly effective for people living with HIV, and the success or the cure rate is 95 to 98%. So.
You want to talk about the local health department? The local health department.
Yes. So out of 95 counties here in the state of Tennessee, we have 61 counties now treating hepatitis C for the uninsured. I can provide, if you reach out to me later, I can provide you with locations and contact who to get connected with for the treatment. But they're all over the state, the 61 counties that are treating for the uninsured. And then we have some counties exploring the insured population as well. So these are a few of the common medications that we're seeing being used for the treatment of hepatitis C. Epclusa, it's 1 pill once a day with or without food, and it treats all 6 genotypes. Then you have Mavorite, which is 3 pills taken at the same time with food, and it as well treats all 6 genotypes. And then Harboni, 1 pill once a day with or without food, but it only treats genotype 1, 4, 5, and 6. So the goal of hepatitis C treatment is to achieve sustained virologic response. And what that is, and this is the example I give in my training, say I had hepatitis C, I was on the treatment, I was taking like Epclusa, I finished my treatment today. 12 weeks from today, the provider would have me come in and do blood work and to check my RNA. If my RNA is negative, then I have achieved SVR or sustained virologic response and I'm cured. And then the secondary goal of hepatitis C is to mitigate progression to cirrhosis, decompensated cirrhosis, and liver cancer. With this wonderful treatment, though, that we also have a lot of barriers, unfortunately. So our syndemic coordination team, which Anastasia is a part of, they conducted a needs assessment. And from the needs assessment, this is what they found out. 30% of people who use drugs reported having lived or living experience with hepatitis C, and 28% of those reported needing hepatitis C treatment and 45% not receiving it. So the top barriers was discrimination, stigma from providers and community. So if someone's going to feel like they're shamed or judged, they're not going to go and get treatment. I wouldn't. I would avoid it. I have pride. There are also the concerns about cost. When I started working with Tennessee Department of Health, the cost for hepatitis C treatment was $90,000 in 2018. It's down to $20,000 to $30,000. If I had thought, like if I had hepatitis C and someone told me the treatment cost that much, I would probably be like, well, why bother me getting tested? I can't afford that, because if they don't know the resources, they're just going to be like, well, I'm not having symptoms, I'm just going to live with it. So we need to break that barrier in our community. Like, there are ways to get you treated, even if you don't have insurance. Other barriers is like homelessness, incarceration, just getting them tested in general. The insurance can be a barrier, or lack of, or underinsured. There used to be a strict eligibility criteria where you had to prove sobriety for over 6 months. Used to, if you were in active use, they would not treat, but they do treat now. Transportation issues can be a barrier as well. If you don't have a car to get to and from your doctor's office, how are you going to get treated? I know I mentioned homelessness. If I don't know where I'm laying my head down at night, why am I going to worry about my treatment? So we just have to work with these individuals and help meet them where they are to get this taken care of for them. So with Tennessee Department of Health, we have what is called Project ECHO, and our focus is hepatitis C, and we're trying to build the hepatitis C treatment capacity among like primary care, pediatricians. We do want our OBGYNs in there, even though right now we cannot treat pregnant persons. But this is 1 hour, the first and third Wednesday at 12 p.m. Central Time, virtual, and you get a free CEU credit. We would love to have y'all on there. With Project ECHO, you can submit cases if you have one. We have subject matter experts where they can review your case, and if you need like a specialist recommendation, that can qualify for your specialist. Again, this is free. We would love to have anyone and everyone on here, and if you need more information, I have to leave as soon as this is over, but Jack can get you my information. So please share that. So perinatal hepatitis C. In Tennessee in 2019, we started a navigation project in our East and Knox regions. That's unfortunately where some of our higher rates are for perinatal, but we were piloting a project to follow the pregnant person who had a live birth and follow the children as well to make sure they're getting tested. And if they have hepatitis C, we want to get them linked to treatment as soon as they're of age or 3. You can see here in Tennessee, we had in 2018, 1,341 infants exposed to hepatitis C. The national average is 6%. Tennessee, we range between 5 and 11%. So since 2019, we have expanded that perinatal navigation program all across the state, and you all have a navigator for Memphis Shelby area. So speaking of navigation, we have 3 different types of navigator roles in Tennessee Department of Health. The individual or the nurse for Memphis Shelby is Laverne Taylor, which you'll see her contact information here in a minute, but she wears all 3 of these hats for the Memphis Shelby area. So the case navigator, she's contacting individuals who are RNA positive and linking them to treatment. She's contacting those that are RNA negative but have a history of incarceration or drug use and giving them resources and education on Hep C, and then the perinatal part as well. This map shows all of our regions and how they're broke up. So again, Laverne Taylor is our Memphis Shelby navigator. She's an RN. She also covers the Jackson-Madison region. And then in our West Tennessee region, we have Jennifer Bird and Carla Ray as well.
Cool. Thank you. Okay, so thank you, Melissa. So knowing all of this, we're going to connect it to strategies to address the opioid crisis. So as a lot of talks already today have mentioned, harm reduction is a practical and evidence-based approach that incorporates effective community-driven strategies to empower people, big underlined under the word empower people, people who use drugs with the choice to live healthy and self-directed lives. It emphasizes engaging directly with people who use drugs to prevent overdose and infectious disease transmission, improve physical, mental, and social well-being, and offer low-barrier options for accessing healthcare. Harm reduction also understands drug use as complex, and it encompasses a continuum of behaviors. Harm reduction acknowledges that some ways of using drugs are clearly safer than others. Lastly, harm reduction is the basic idea that people's lives have value regardless of their drug use. Another huge piece is the any positive change approach, which moves away from that all or nothing approach. So instead, improvement is defined by the individuals themselves, not the providers. It's about their quality of life and what matters to them. And this helps build that self-efficacy and their confidence, and it leads to more sustainable changes. And it often leads to less harmful relapses because the person is equipped with resources and tools available to reduce those relapses. To implement that positive change, it's important to have the collaborative conversations about the harms and benefits of a client's substance use behaviors. And that means letting the client set the goals, which can range from safer use, abstinence, reduced use, or it could be something unrelated like obtaining an identification card or getting tested for hepatitis C. Working with the client to identify achievable steps, offering relevant suggestions, and providing linkage to necessary services is always best. And it's also best to be supportive, praise accomplishments, reaffirm confidence after setbacks, and reevaluate goals as needed. And again, big underline under this, remember that harm reduction is about empowering people who use drugs to live healthy and self-directed lives. So one harm reduction strategy that I'm sure many of you are familiar with is syringe services programs, which are evidence-based public health programs that provide low-barrier comprehensive harm reduction services, including access to and disposal of sterile syringes and injection equipment, naloxone and overdose prevention education, infectious disease testing, care, and linkage to substance use disorder and mental health care, as well as supportive services like housing assistance. SSPs are more than just needles. They're a status-neutral strategy for all conditions, meaning they aim to provide high-quality care to everyone, regardless if the care is for treatment or prevention. SSPs also provide their services in an environment that presents as few barriers as possible, like a convenient location, anonymous services, or extended hours. And the goal, of course, is to meet the client where they are and to offer these wraparound services that are ready when the client is ready to receive them. So over the last 3 or so decades, studies have shown that SSPs are associated with an estimated 50% reduction in HIV and hepatitis C incidence from providing the sterile equipment, disposal of that equipment, and acting as a bridge to different health services such as testing and treatment. And so when Scott County, Indiana implemented the syringe services, they saw an 88% reduction in syringe sharing. And by 2018, so about 3 years after the outbreak, Scott County saw a 96% reduction in new HIV infections and a 76% reduction in new hepatitis C infections. This outbreak showed that the earlier SSPs are implemented, the more community HIV and hepatitis C cases that can be averted. So beyond sterile needle and syringe distribution, as I mentioned, SSPs help link participants to prevention activities such as infectious disease testing, pre-exposure prophylaxis for HIV, as well as linking clients living with HIV or hepatitis C into care. Additionally, SSPs help reduce needle stick injuries, where a study found 86% fewer syringes were found in parks and sidewalks in communities with an SSP. One major misconception about harm reduction in SSPs is that they're anti-recovery or anti-abstinence, where neither are true. Harm reduction provides those tools to stay as healthy as possible before, during, and in between people's experiences of recovery and abstinence. Another misconception is that harm reduction interventions promote drug use among people who use drugs or encourage people to start, but this is also not the case. SSPs offer referrals to substance use disorder treatment, and evidence shows that new users of SSPs are 5 times more likely to enter drug treatment and 3 times more likely to stop using drugs altogether. SSPs provide that non-judgmental and accessible service model, and that leads to building trust, where clients return to the SSP to get other services related to their health and life when they're ready. On the slide, there are a couple of ways that drugs are consumed and different vulnerabilities with each method of use. As we discussed before, harm reduction does not seek to ignore the real harms associated with drug consumption, but seeks to mitigate them through safer consumption practices and recognizing that some forms of consumption are safer than others. And so with all of these methods, there's potential to overdose or overamp, depending on the drug. And out of the 5 methods on the slide, injection carries the highest risk for bloodborne pathogens like HIV or hepatitis C compared to other methods of consumption, but these risks, again, can be mitigated by safer injection practices. But as you may notice, almost all of these methods have a potential to transmit hepatitis C if blood is present. And if you recall what Melissa said, hepatitis C can live on surfaces for up to 6 weeks if not properly sterilized. So even if the blood is wiped off, even if even if the blood is wiped off, even if you rinse off injection equipment, the blood particles still might be on there and can live for a while after that. So that's why, again, sterile equipment is best. So on the slide, we now have different examples of strategies that people can use to reduce their risk of getting HIV, hepatitis C, and sexually transmitted infections. And not everyone you work with wants to or is able to commit to taking, for example, pre-exposure prophylaxis for HIV, or maybe they're unable to commit to using new injection equipment every time. But using new syringes every time a person uses drugs requires constant access to new equipment, and that's just not feasible. So this is why we have so many other creative ways that harm reduction can step in and be that infectious disease prevention. Even just using injection equipment more often than they currently do would be reducing chances of getting bloodborne diseases like hepatitis C, or maybe someone switches to a different method of consumption such as smoking, which we know has less vulnerability to infectious disease transmission and overdose than injection. This also counts as any positive change. Something that's not on this slide, but that's relevant to the previous one, is about smoking. One SSP best practice that we're seeing around the state is that SSPs are giving participants chapstick and educating them on the importance of keeping their lips from being dry. The drier they are, the more likely they'll crack and bleed, which can increase their vulnerability to hepatitis C transmission if they share equipment with other people. So what does this look like in Tennessee? So SSPs were signed into Tennessee law in 2017 with a couple amendments in 2018 and 2023, where non-governmental agencies and local health departments can apply to operate an SSP following approval by the Tennessee Department of Health. In our most recent amendment in 2023, it standardized zoning requirements across Tennessee. It used to be in Tennessee, it used to be 2,000 feet from the school or park, except in our metro areas where it was 1,000 feet. But now it's 1,000 feet across the board, except for one municipality, which is, again, any positive change. The Tennessee law also outlines the services that must be provided by SSPs, so that free, unused needles and syringes, the disposal for that equipment, access or referrals to naloxone, serving as a bridge to link clients to all different types of testing and treatment, and providing prevention education. So as of October, actually as of November as well, these are the counties across Tennessee with at least one SSP. So raise your hand if you've ever been to an SSP. Okay, a couple people. Can anyone name an SSP? You can just shout it out. Yes, Safe Point. Here is a list of all the SSPs in Tennessee. I've marked the ones in red that are in Memphis, and then the one in lighter blue is in West Tennessee. We have a bunch in Memphis. You can also find this information at our website, or you can just ask me. I'll be here probably the rest of the conference. Something also interesting, at the end of 2022, we had 16 SSP locations. Some places had multiple locations, some places only had one, but 16 in total. But by the end of 2023, we had 32 or 33, which is really cool that we expanded them so much within 1 year. So we're really grateful for our community-based organizations for working with us, working with the community to fight that stigma and get these services out to everybody. So the SSP team at the Tennessee Department of Health, which consists of myself and my invisible person, Rebecca Amatia, we oversee the SSP application, and we provide technical assistance to those interested in becoming an SSP, and we help them develop strong best practices and navigate the SSP application in general. We've also built a community of practice among the SSPs by coordinating statewide calls, so everybody across the state can share resources with each other. We give some state updates from the department, things of that nature. We also provide ongoing support through individual calls with our agencies. We do site visits. And we also put on trainings like our harm reduction training that we put on in partnership with our capacity building assistance team. And we oversee data and monitoring and evaluation for SSPs across the state and produce an annual report. And that shows where SSP services were located, who they served, and the services provided during that calendar year. I also have my email on the slide, but it's also at the end. So just to wrap this all together, you can also be part of the movement to eliminate hepatitis C. You can educate the community on hepatitis C transmission by telling people about their vulnerability and working to mitigate it. You can break barriers to testing and treatment by meeting people where they are and working with clients in their healthcare plan. You can provide harm reduction services to the community, from sterile equipment to overdose reversal medication like Narcan, and you can also provide wraparound services. You can also join our Project ECHO to increase your treating capacity to treat people with hepatitis C, from adults, postpartum people, and infants. And as always, we want to offer services free from stigma and discrimination. Lastly, we like to end on this quote from that recent needs assessment that Melissa mentioned, and it really sums up everything I just said. That most people, if they took the time to speak to, they're just as nice as your neighbor next door. They may have a drug issue, and a lot of people do, but they're still human. They still need human contact, they need kindness, they just need a little support, or just a kind word makes all the difference. Just don't judge, don't judge. And this is a person living with HIV, a person who uses drugs, and who is experiencing homelessness.
So on this slide, you can see we have a lot of resources that we can get for you if your agency needs them. We have information, of course, on hepatitis C, the fast facts, the viral hepatitis that will have A, B, and C on it. We also have information on xylazine, overdose prevention, and SSPs. So we can get that for you. Again, just another plug for Project ECHO. We would love to have you all join us on the first and third Wednesday of every month at 12 p.m. Central. Again, it's free. Most professions, such as pediatricians, medical providers, nurses, pharmacists, social workers, they can all receive free CEU credit. So rapid hepatitis C testing. I oversee the rapid hepatitis C testing project in the state. Right now we have 26 partnering agencies. Those are CBOs or free health clinics. So what we do, we provide them with rapid hepatitis C test kits, controls. We provide them training in person for their staff and their volunteers. And then they, of course, when they test, they have to submit their data to us every month. And we also provide them support and technical assistance with rapid testing. So if you're an agency or you know of an agency that is interested in becoming a rapid hepatitis C testing partner, we have an interest survey on REDCap that you could fill out. And again, this is our contact information. I'm Melissa, she's Anastasia. Amber couldn't join us today, but we can get you connected with any of these resources that we spoke about. Thank you.